to remote regions. Allow me, please, to answer this call because I am on duty. Just give me. Right. So, virtual reality and simulation based training, especially in advanced procedures, is helping to reduce the learning curve for complex surgeries, ensuring that surgeons are better prepared for all life operations. Global surgical fellowships are also playing a critical role in capacity building. These fellowships enable surgeons to low and middle income countries to receive advanced training in high income countries, where they can learn cutting edge techniques and bring that knowledge back to their home country. Another important trend is the expansion of online learning platforms. The COVID 19 pandemic has accelerated the adoption of virtual classrooms, allowing surgical trainees to attend lectures, participate in case discussions, and even observe surgeries from anywhere in the world. Going forward, we'll see greater integration of surgery within public health system. For example, non-communicable diseases like cancer often require surgical intervention. Trauma systems need to be strengthened across Africa, and maternal and child health must also incorporate surgery to reduce mortality, especially in emergency situations like obstetric complications. Surgery is an investment, not just a cost. Expanding surgical services leads to long-term economic gains by reducing disability, improving productivity, and lowering mortality. Governments and international donors must recognize the value of investing in surgical systems to strengthen the health system overall. Africa is home to growing number of visionary leaders who are driving innovation and improving surgical care across continents. These surgeons are not only advancing clinical practices but also advocating for better health policies and contributing to development of national, regional surgical plans. For example, is Dr. Emmanuel Makasa, a Zambian orthopedic surgeon and a global surgery advocate who has been instrumental in providing the inclusion of surgery in global health agenda. His work with WHO and United Nations has helped raise awareness about critical need of surgery in low and middle income countries. Another leader is Dr. Sherry Wren, a surgeon at Stanford University who has worked extensively in conflict zones and low resource settings, particularly in Africa. Dr. Wren has helped develop surgical education programs that are tailored to a specific need of low middle income countries, focusing on sustainability and capacity building. Local innovators are also making significant strides. In Nigeria, Dr. Olyunka Olutoye gained international recognition for successfully operating on a fetus while it was still in mother's womb. His work highlights the potential for African surgeons to lead in complex surgical procedures. By fostering local talent and creating opportunities for African surgeons to innovate and lead, we can ensure that the next generation of surgical leaders is prepared to address the unique challenges facing the continent. Policy will play an increasing important role in shaping the future of global surgery. The WHO is actively advocating for surgical care to be included in national health plans, and national surgical plans are becoming a central part of universal health coverage efforts. Looking beyond 2030, a global cooperation will be key to continuing progress. In addition to WHO, regional bodies like African Union are increasingly focusing on health issues, including surgery. The African Union's 2063 agenda emphasizes the need for healthy and prosperous Africa, and surgical care is an essential part of that vision. Artificial intelligence and data analytics are set to revolutionize the way surgical care is delivered, especially in low resource settings. AI is already being used to assist in preoperative planning, where it can analyze large sets of patients' data to predict potential complications and guide surgeons in making better decisions. For example, AI algorithms can help identify which patients are at higher risk for complication, allowing healthcare teams to make preventive measures before surgery even begins. AI is also making integrated into interoperative decision making. In real time, AI system can analyze data from surgical instruments and monitoring equipment to provide feedback to surgeons during the procedure. This can help surgeons to make more precise incisions, monitor blood loss, and even predict the likelihood of operative complications. On the data analytics front, big data is playing a crucial role in tracking health outcomes and improving the overall performance of surgical systems. By analyzing data from thousands of surgeries, health systems can identify trends, spot inefficiencies, and develop evidence based strategies for improving care. In Africa, where resources are often limited, data analytics can help maximize the use of available resources by identifying which interventions are most cost effective and which areas need the most investment. By leveraging AI and data analytics, we can improve not only surgical outcomes but also the overall efficiency of healthcare systems. Achieving equity in surgical care is the ultimate goal of global surgery. Today, we face stark inequalities in access to surgical services, particularly between high income and low income countries. But even with low income, there are disparities based on income, geography, and gender. For example, women in rural areas often face greater barriers to accessing obstetric surgeries like cesarean section, while people living in poverty may be unable to afford even a basic surgical procedure. To address these disparities, we need to focus on universal access to safe, affordable surgical care. This means ensuring that surgery is not just available but also accessible to everyone, regardless of their socioeconomic status. Financial protection is the key. No one should be pushed into poverty because they need surgery. Governments must work to provide insurance schemes or subsidies like that cover the cost of surgical care for low-income population. In addition to financial barriers, we must overcome geographical barriers. This means investing in surgical infrastructure in rural and remote areas where access to healthcare is often limited. Expanding mobile surgical units and telemedicine platforms can help bridge the gap between urban and rural healthcare facilities. Finally, we must tackle cultural barriers, including gender discrimination and stigma around certain types of surgery. By addressing these barriers head on, we can move towards a future where surgical care is equitable and accessible to all. Let's take a recap. The key points from today's presentation: surgery plays a crucial role in global health, saving lives and improving quality of life. We have explored the historical evolution of surgery, current challenges in access and workforce, and exciting future trends, including technology, policy initiatives, and innovative training methods. Now, I would like to leave you with a call to action. As doctors, advocate for better surgical policies and increased investment in surgical care in your country. For those in global health, focus on building partnerships that can improve surgical care in low and middle income countries. Together, we can create a future where surgery is accessible to everyone, everywhere. I'll leave you all with this thought. Will it be easy? No. Will it be worth it? Absolutely. Thanks a lot for your kind attention. The House floor is open to questions, otherwise, we'll be going on to the next presentation.
Thank you, Dr. Jagpreet, for your wonderful presentation. I would like to open up the floor for any questions that may arise from the doctor's presentation. Anybody that has a question, you may raise your hand and allow you to unmute. It may be a question or a compliment. The floor is open before we proceed to the next presentation by Mr. Kevin.
Right, and respecting the time of everyone, I think let's move on. Anyway, I think I have really obstructed Kevin, and I'm sorry to do like that because of my work schedule, because I am working right now. So I will disconnect from here, then go to my OP and rejoin from there. Thank you very much. Thank you very much for understanding, Kevin. Really, thank you very much. Thank you, Kalemba.
That's okay.
I think since no questions have arisen, let's proceed to Mr. Kevin so that he gives us his presentation. You're welcome, Mr. Kevin.
Hello, I'm just trying to get to share the screen. I'm not quite... No, doesn't seem to be allowing me to. Okay, let's see if I can get to the screen. Can you see?
Yes, you can see.
Can you see the screen, the presentation?
Yeah, we can see it.
We can see it. We can see it. You can see
Oh,
it.
you can. It's just I can't. Anyway, what I'm going to say this afternoon, and I'm pleased to meet you all, is say something about the history of surgery. Now, I've written a number of books on the history of medicine, and I've only just scratched the surface of that subject. So what I'll do this afternoon is talk about some of that work and also use some examples to simply look at ways in which the history of medicine can impact on the future. Now, So, I am also, as well as an author of books on the history of medicine, I have in the past been chairman of the London Museums of Health and Medicine. And there are a wealth of places you can visit all over the world which help you to understand some of the background to modern surgery and medicine. And I think that's the important thing, being able to understand what happened in the past. Now, in London, there are at least 24 medical museums. I'm curator of one of them, the Alexander Fleming Laboratory Museum at St Mary's Hospital, Paddington, the birthplace of penicillin. It was in this old-fashioned, low-tech, musty, bit dusty lab that Fleming discovered penicillin back in September 1928. And I would argue that it was there that the antibiotic age in medicine had its beginning. And I hope you'll come to understand the importance of the role penicillin has had in the fight against infection and in allowing a lot of modern complex surgical procedures. Alexander Fleming originally wanted to become a surgeon. However, when he qualified as a doctor in 1908, there were no vacancies available at St Mary's Hospital. So he went into bacteriology. And if you'll pardon the pun, he got the bug. He later claimed that as he'd gained the fellowship of the Royal College of Surgeons, he had the distinction of being the only surgeon never to have operated on a patient. Well, perhaps he wasn't the only one. Now, when he came to discover penicillin, and when penicillin came into widespread use, one of Fleming's colleagues at St Mary's Hospital, Paddington, commented that Fleming would put more people out of work than anyone else in history. By that he meant himself and fellow surgeons. That time, penicillin was seen as the universal panacea, and it was thought it could treat anything. Well, I'd argue that in actual fact, the antibiotic revolution was to offer a means of controlling infection which allowed surgeons to do a lot more than they had done in the past. Well, I also, in this short talk, want to talk about the relationship between war and medicine. Surgeons occur in classical literature and in art. They are mentioned in Homer's Iliad and were essential for the Greek war effort against Troy. Here you can see Aeneas being treated for a wound. Very stoical he seems to be, although his son Ascanius seems to be quite upset by what the surgeon is doing. In the Middle Ages, there were even surgical saints, St. Cosmas and Damian, two Christian martyrs who were depicted as pioneers of transplant surgery. What is most interesting, though, is that they are shown transplanting the leg of an Ethiopian corpse onto a living Caucasian man. Well, anything can happen in mythology and religion. But in reality, conditions could be difficult, especially at sea. Nelson, who I've written a biography of from the medical point of view, looking at his role in promoting the health of the Navy, seems to have been unable to keep out of the hands of the surgeons. He lost his sight in his right eye at Calvi in Corsica in 1794. He lost his right elbow at Santa Cruz, Tenerife in 1797. Suffered a head wound at the Battle of the Nile in 1798. And here you can see him being treated in the cockpit of his ship by the surgeon's mate, whilst the surgeon operates on a leg wound. They all look remarkably cheerful, but contemporary depictions of the cockpit, the scene of the work of the surgeon in battle, of which this is perhaps the only contemporary one, drawn at the time, show a scene of confusion. Now, there was some form of basic triage intended. The idea was hopeless cases would just be left, and the surgeon would concentrate on injuries that could be treated. But things would happen so quickly, there would be no time for any form of triage. Now, success could be measured by survival after the battle. And we all know that Nelson did not survive Trafalgar. Amputation in such conditions was performed without anaesthetics. And a big breakthrough came in 1846 at Massachusetts General Hospital in Boston, when William Henry Morton demonstrated the use of ether as an anaesthetic. Perhaps more significantly, for allowing successful surgery was the work of Joseph Lister. Basing his ideas of infection, learned from Ignatius Semmelweis, and also from the new understanding of how infection could be caused by bacteria. In 1865, Joseph Lister began to argue for aseptic surgery. It's quite interesting to look at a sequence of operating theatres over the years, the changing scene of the theatre. In the 1850s, surgeons at St Mary's Hospital, Paddington, would take turns to operate. And if one of them had a particularly messy and nasty case, the others would allow him to take the next turn, so he didn't have to clean up. I should say they kept dirty, blood-stained coats to change into, rather than dirty and sully, they fine chalk coats. So there was no understanding that they were actually decreasing the patient's chances of life. And then, even by 1898, you have students, medical students, wearing street clothes, watching from the gallery as part of their training. So by now, aseptic surgery had come in. But, as you can see, there were open coal fires, and the conditions in the theatre were far from ideal by modern standards. The idea was to control infection in the theatre by the use of carbolic acid sprays, the use of antiseptics. However, many surgeons objected to working in such conditions. Not only could the carbolic affect the tissue of the patient, but also it was for them like working in a sauna in a Turkish bath. These sprays of carbolic acid were uncomfortable. So the move was away from antisepsis to aseptic techniques. And here you see a modern theatre of 1928. Much more hygienic than the previous one we saw, but still not perfect. However, it was getting there and moving towards modern theatre conditions. Although, of course, modern theatres have much more equipment. In the United Kingdom, purpose-built theatres were not ideal during the Second World War. Most of them were on the top floors of hospitals to make the most of natural light, but that made them vulnerable to air raids. So temporary theatres were set up in wards. Here you can see one depicted by the artist Stanislaw Kaizen, who was present during the operation. You can see an operation performed in a temporary ward in 1944. But war could be a catalyst for change. And for this, I'm going to look at the experience of the First World War. When it was said by General Keogh that we were back to the septic conditions of the Middle Ages, it was noted that modern ballistics were having the effect that virile bodies were brought to nothing but a slug on the ground. Alexander Fleming actually demonstrated that the use of strong antiseptics by medical officers as first aid was doing more harm than good. He did that by constructing an artificial wound from a glass test tube. And he showed that the antiseptics were killing off the body's own defences, the phagocytes, much more quickly than they were killing off the invading bacteria. Result, gas gangrene, often loss of limbs. And also that the glass test tube showed that antiseptics could not penetrate the jagged wounds of modern ballistics. His answer, simply keep the wounds clean and wash it out using a mild saline solution. It was sensible advice, ignored until the Second World War. Doctors and generals have at least one thing in common. Neither likes to be told what to do. Well, during the Great War, the casualty clearing station, such as this one, was the scene of most emergency surgery. And it was realised that early surgical intervention was essential if there was to be any hope of survival. But, as you can imagine, working conditions were abysmal. Harvey Cushing, an American surgeon from Harvard, described working in utter confusion, amputations of the thigh, sucking chest wounds, mutilations, the German wounded stinking. Well, he was so exhausted by it all that he lay down on his operating theatre, fell asleep and fell off. He was to pioneer the use of magnets to extract objects from the brain, metal objects. So you could argue that the First World War was successful for surgery in introducing new technology, new methods, new ideas. However, much of this innovation had actually been argued for before the war. Well, operating conditions were little changed by the Second World War. As you can see, a surgeon operating in a mobile theatre during the Second World War. But there were even worse challenges to be faced in the Far East. Surgeons such as Weary Dunlop, seen here, had to operate as prisoners of war in the most basic of conditions. They had to improvise massively. They had to tie bamboo together to form an operating table. They had to use whatever they could get hold of, as in terms of scalpels, sterilising in mess tins, whatever they could get hold of. It was all very make-do. There was nothing else they could do. However, the Second World War was to see for the first time a means of controlling infection, antibiotics. Alexander Fleming had discovered penicillin, as I said earlier, on the 3rd of September 1928. But it wasn't developed until the early days of the Second World War at the University of Oxford by a medical research team led by Howard Florey, and which included the biochemist Ernst Chain. Now, Fleming was very much the lone researcher and had been unable to isolate penicillin. The Oxford team succeeded because they were working as a medical research team. And that was an indicator of the future, both of medical research and surgical practice. The days of the heroic lone surgeon were about to come to an end. And also, multidisciplinary teamwork was essential for progress. Well, penicillin came into its own during the liberation of Europe. And you could say that the development of penicillin was accelerated by wartime conditions, just compared to the development of the COVID vaccines. In both cases, you have a medical emergency. Everything happens much more quickly than it would otherwise. The difference, though, between 2020 and 1941 is that the vaccines were based on existing knowledge and technology. With penicillin, they were working in the dark. They were using it, and it worked, but they didn't know what it was or how it worked. However, very much you could ask the question, had Fleming actually put surgeons out of work? Well, the answer, of course, is no. Antibiotics and having a means of controlling infection made it possible for surgeons to do more complex work. And we can just take any examples we want. 1960, kidney transplantation, 1962, hip replacement, 1968, heart transplants. And also at the same time, new technology, such as scanners and MRI, were transforming the practice of medicine. And new ideas. Test tube babies in 1978, MRI scans. But antimicrobial resistance is now a major problem. Fleming actually warned of those dangers 81 years ago, as long as 1943. For him, penicillin should be used sparingly. But as new antibiotics were developed or existing ones modified, the problem could be kicked into the future. The future is now. So that is your challenge. Fight antimicrobial resistance. Without it, the future of surgery will be bleak. Surgeons, like all of us, need to embrace change, but they also need to retain a sense of humanity and avoid the 19th century attitude of mind satirised by Charles Dickens in Pickwick Papers when he wrote of medical students, "There's nothing like dissecting to give you an appetite." The appetite should be for progress. So over to you. So, any questions?
Well, Kevin, that was a wonderful presentation. And your voice and the way you talk is so pleasing and so soothing to the ears. I was almost floating into history. Thank you very much for presenting the historical aspect of surgery and medicine. Thank you very much.
Thank you.
I'd like to take this opportunity to thank Mr. Kevin for his wonderful presentation. We truly appreciate the effort that you put in all these historical facts and put them together into one wonderful presentation. We truly appreciate. I'm trying to reach out to the third speaker, but in the meantime, allow me to invite one of the patrons of this society here. Is a senior health officer and a surgeon working in the rural parts of Uganda. So I'd like to invite Dr. Mumbere to give us a few remarks here and there as we wait for our third speaker.
Mm.
For any questions or compliments or comments that may arise from the presentation by our two presenters. You can raise your hand or unmute and and also the meeting is being recorded and it will be uploaded onto YouTube and our other streaming platforms for our different individuals who have had a few difficulties here and there and have not been able to join us. So any comments or questions, they are welcome. I'm seeing some comments coming in.
Vegetarian.
I'm seeing a hand by Tinka. Tinka, you can unmute and we see what you have to say.
All right. Good evening, everyone. For me, I'll
Good evening.
just to give my vote of thanks to Mr. Kevin Brown and also Dr. Jagpreet. There have been wonderful presentations, and yeah, if possible, I would really love them to also come back some other time, and they will also add. The words have been very, very valuable, and I feel that they will indeed help us in our endeavor. Thank you.
Thank you, Farhat, for your comments. Are there any other comments or questions that may arise from our presenter's presentation? I'm seeing a hand by Nwagaba. Nwagaba, you can unmute and we see what you have to say.
Yes, first of all, I would like to say thank you to number one to the society for organizing such a conference, and also thanks to our dear guest speakers. And maybe the only question I would have, given the experience that they have had as surgeons, the experience and the expertise they have, what is the best word of advice that they could give to us who are, as per now, undergraduate students but are looking forward to doing surgery and subspecialties in surgery? That's the only question I have. Otherwise, thank you so much.
Well, I'm not a surgeon, I'm a historian, but I've learned quite a lot about surgery. But I'd say one of important piece of advice for you is actually keep your humanity, keep an open mind, and also be open to change. I think that's vital in modern surgery. Now, I'm saying that both as a historian who studied the past, but also I do have a lot of contact with current doctors and surgeons in the course of my work as archivist to St Mary's Hospital in London. So I'll say to you what I say to them. Just persevere and do your best. And who knows, you might get a Nobel Prize for it. But above all, you'll have the satisfaction of having done your best to achieve whatever your aim is. So good luck with that.
Okay, thank you so
Hey,
much, Mr. Brown.
hey, Kevin, you really put forward a phenomenal piece of advice, and as you said, it is not just for you; it's not for a surgeon, for anyone. And I believe I would certainly like to um, uh, second that thought of perseverance and hard work, which is synonymous of being a surgeon. So I think I will ask you to continue with your efforts. Try to get into the highest level as much as you can. Try to affiliate yourselves with the institutions, not only locally and abroad. And I believe, as I said, there's a lot of brain drain. So if you go out, try to come back because there is wealth sitting back home. So wealth of treasure of patients and the people who need your services. So try to get max knowledge and try to serve the people who brought you into the training and the system. So that's my short message. All the best. Bye bye.
Yeah, thank you so much. I am really humbled by the piece of advice that we have got from you, and we shall put it into practice. Thank you so much. Maybe another question I would have to ask is if I'm to finish my medical degree from here in Uganda, in Africa, do I have some, like, what chances do I stand? Are there like opportunities? Like, what would be the path for someone who has done their medical degree from here, for example, to do their masters in surgery from abroad? Like, except apart from the degree, I know that there may be some other requirements that may be needed. And what's the best way, the best pathway? There might be different pathways. What are the best pathways that you would advise us to take after our degrees here, in case we want to do surgery to pursue further studies in surgery abroad? Thank you so much.
Any of the two, Mr. Kevin Brown or Dr. Jagpreet, would you mind to help answer that question?
Well, I'm not the best qualified person to talk about that, as I've said, I'm not medically qualified. However, I do know several students who were progressing in the United Kingdom who have come from overseas countries. Now, it's not easy, I don't think. There's a lot of hurdles to go through in order to get visa requirements met and so on. But I think most of the people who've got through those hurdles have been able to contribute massively and also gained a lot from working in another culture and another country. And of course, medicine and surgery are international and should be.
Alright, I think Nwagaba, your question has been well answered, except if there is Dr. Jagpreet, you want to answer?
Yeah, I mean, what is happening, as I told. So I was visited by a patient, and now I am just. So I believe the question was regarding how you would like to go ahead further into training, and you want to visit internationally. Was it correct? Can you just repeat your question? If is this not correct?
Yes, Dr. Jagpreet, my question was, after I've done my undergraduate degree in medicine here in Uganda, particularly at KIU, because that's the university I'm at now, do I stand chances of doing perhaps my master's in surgery from abroad? Let's say, for example, in England. If I stand a chance, I know it's not only the degree that is required. There may be some other prerequisites that I may need. And so, what are the best pathways? What's the best advice that you would advise me to take after my degree for me to pursue my surgery from abroad, my master's in surgery from abroad? What would be the best advice for me to do that? Thank you so much.
Okay, so if you would like to go to India for your further training, that's a brilliant idea because there's a wealth of patients and expert surgeons of very high caliber to teach you. There'll be some kind of a licensing exam that you must pass in order to be eligible to compete in the exam for postgraduate entry. And I believe once you get through that, I think you're on your way to further training. However, you can always try at multiple places because surgery is a very popular branch and there is immense demand. There is less number of seats and immense number of candidates who are trying to get those seats. So I believe you can try multiple places and see which one accepts you, or if multiple accept you, then you can pick and choose. Right? Did that answer your question?
Yes, please, sir. You have answered my question. Thank you so much.
Yeah, take care. All the best. So please excuse me if I don't answer because if I'm visited by a patient, I'll have to switch off because as I told, I'm working today. So I moved from this hall to my clinic now. So yeah, let me just reconnect with you in a just a second. Okay.
All right. Except if there is anyone else with a question. Anyone else with a question, you can raise up your hand and then say something. Anyone? In absence of any question, on behalf of my friend Kalemba Fahd, my boss, I would like to thank everyone who has attended and also our presenters for sparing a little bit of their time from their working schedules to come and be here with us. Would very, very much be appreciative of the hours you've given us, and we hope they are going to be very important to us. Mr. Kevin Brown, Dr. Jagpreet, thank you so much for sparing time for us. Kalemba is back. Kalemba, I think you can now take over.
I'm sorry, I had a few connection issues here and there, but I would like to thank our speakers for the wonderful presentation and everything, which we truly appreciate, and we believe that the information you've shared with us is enough to ponder and to some extent help revolutionize the medical field in Uganda and Africa at large. Before I went off, we were waiting for a submission from our patron, one of our patrons. I believe he has more experience than majority of us, the audience have, because been in Uganda for to give remarks before to our presentation. If he's on, if he's off, he has a few connection issues here and there, but I'm seeing a hand. I don't know if it has been raised. I'm seeing a hand. I don't know if it's a compliment, or as we wind up and conclude on our discussion. So, anybody with some final remarks or comments or suggestion, it's welcome before we conclude. You can raise your hand. If your hand, you can hear what you have to say.
All right. Thank you very much for this fine opportunity. I appreciate the presentations that have been made. My question goes to Mr. Kevin Brown. As mentioned earlier, he said he's an historian in surgery, and he wrote books about the progress and history of surgery. I would like to know the names of some of these books, because I really love the presentation. As a student going to surgery, I do want to know more about the history of the occupation and the profession that I've chosen. So it would be really wonderful if I could know some of the names of the books he has written. Yes.
Oh, thank you. Well, as it happens, the first one I had published was published exactly 20 years ago tomorrow. Penicillin Man, Alexander Fleming and the Antibiotic Revolution. I've also written The Pox, The Life and Near Death of a Very Social Disease, which is all about the history of syphilis, both the medical, surgical and cultural history. I've written Fighting Fit, Health, Medicine and War in the 20th Century, which looks at developments in medicine, both on the home front and at war, from 1898 up to 2001. Pox and Scurvy, A History of Medicine at Sea, which looks at health, medicine and surgery on ships from the classical times up to 1996. I've also written Passage to the World, which looks at the role of surgeons on emigrant ships, and Fittest of the Fit, which is the story of the health of the Royal Navy during the Second World War. As a change from medicine, next year I will have published a book called Titanic, Ship of Lost Illusions, which has nothing to do with medicine. So a bit of diversion for me. I've also written a number of articles which deal with the history of medicine. The most recent was one on coolie ships from India and Africa and China to the New World. So covered a lot of things in my time. A lot of them are available on Amazon and still available, both hardback, paperback and Kindle. So I hope that helps.
Well, thank you very much, sir. I'm sure it will really do. Thanks for your presentation.
Thank you.
Thank you, Mr. Kevin, for those wonderful comments. I'd like to know whether there's any other question or comment from our audience. I'm seeing a hand up. You can unmute and we hear what you have to say.
Yes, my question goes to Dr. Jagpreet. If I've seen, yes, Dr. Jagpreet, my question is for you. My interest is to pursue neurosurgery, but then I've seen that usually there are two pathways. With some people do just a preliminary year, that's 1 year, where they just learn the basic principles of surgery, then they continue to neurosurgery. But then there's also another pathway where you have to first do all the 5 years of general surgery, then later you can do the 7 years of neurosurgery. That's after you finish the 5 years of general surgery. So my question to you is, what would be the best pathway to take? To do the preliminary year in surgery just 1 year, then proceed to neurosurgery, or to do all the 5 years of general surgery, then later do neurosurgery? What would be your best advice on that, sir? Thank you.
Yeah, sure. I believe the way forward will be to achieve your certificate of a trained surgeon as quickly as you can. Okay. However, don't think that you will become a surgeon ready to practice outside your hospital or unsupervised even after getting a certificate. Most often, you will require to put in more years to be unsupervised surgeon, but in a controlled environment like a university or a university attached hospital before you become really proficient to dispense your surgical procedures out in the public. So my advice will be to find out the shortest route to get your certificate, but be prepared to put in more years before you finally get into independent surgical practice, a private or a public.
Oh, thank you so much, Dr. Jagpreet, for your advice. Thank you so
Thank
much.
you. Thank you.
Thank you, sir, for those wonderful comments. Are there any other questions or comments from our audience as we wind up? You can raise your hand.
See, one comment I would like to give to many questions to me are regarding their career pathway. But I finished my training almost 24 years back, like I completed. So many things have changed. I'm into training new undergraduate doctors who come to me who are MBBS, and some of them online for, but this is online, who are based in under the University of Edinburgh. So many of the pathways which I'm talking may have changed. So you please, my request to you, and please pardon me for this about my knowledge, which may be lacking the latest, pathways and latest modifications which would have happened. Okay, so please do check with the pertinent university or the country that you are seeking to further your career uh, endeavors. Okay,
Uh,
right. Thank you. Thank you.
thank you, Dr. Jagpreet.
Forgot
I
you.
think we are going to have our final remarks from one of our patrons, Dr. Mumbe, and then each of our speakers gives us their final remarks, and we call it a day. Um, Dr. Mumbe, the floor is yours.
Okay. Good evening, everyone.
Good evening to you, sir.
Okay, thank you, Mr. Kalemba, for organizing this session, and also my thanks to Dr. Jagpreet and Dr. Kevin, our dear guests,
Wanasema senior surgeon.
for today and the speakers of the day. Uh, I would like to ask you something to Dr. Jagpreet before maybe I finish my remarks. First of all, thank you for your wonderful presentation about the historical, the presence, and the future perspective of global surgery. It was really an amazing presentation, and it was waking us up in various capacities on how we can intervene to influence this global surgery. But
If people go and take any training, they must try to come back and serve their people, because there is a shortage, at least in the rural areas. Um, some of the surgeons they take initiative. Like in 2000, I have visited Uganda, Gulu Hospital, Independent Hospital. We conducted laparoscopic training in the Gulu Independent Hospital. So some of the surgeons and their teams they take initiatives to travel and do trainings in the in such countries. There is through the government level various collaborations with various countries. So I'm sure you can check which countries you have collaborations where there can be an exchange of the doctors between the countries. So they will go take training and then probably come back, stay there for some time and come back. I do find with in where I work, I'm also an expat where I work. I'm an Indian, but I work in the UAE. I have so such people already they are coming here and working, taking the experience, and some of them they are keen to go back and work. But this is a private hospital where I work. Most of the partnerships at government level occur with the government, big government teaching institutions, which will regularly take some people coming here and there. But all those who are interested to work, there is a simple licensing exam. They can come take the exam and start working, gain the experience from this place. Those are my thoughts about what we can do at our personal level. But yeah, at government level, yes, there can be investment. And as I highlighted, and as it is there in the studies, that investment in surgery is a beautiful thing because when we treat anything with surgery, we are eliminating that disease totally. It is unlike treating chronic diseases which require lifelong medication, where the expenditure will be much higher. In surgery, when we invest, we we save lives and we eliminate the disease so that the final expenditure on the health reduces. So it's a beautiful thing. All investments by the governments, politics, or big enterprises and big, the corporates, it is very favorable for any community whenever they invest in surgery. And then there are always fellowships. People can take fellowships, take training, and come back. All over the world, there are some fellowships where surgical fellowships they can attach, take training, and come back. That's what comes to my mind right now. Thank you very much. I hope I just tried to give what I had in my mind.
Thank you so much. Thank you so much. It's so amazing. Ready to continue this. I would like to say this that we shall be hashing sessions. So please, I beg that next time maybe we hit you in box and request you to come and give another presentation in sort of mentorship, because our organization is having surgeons who are already in practice. We have residents who are studying surgery. We have undergraduates who are also aiming to become surgeons. So this is a kind of mentorship and updating our knowledge every day. So I hope you will continue cooperating with us in delivering mentorship and knowledge to the young ones and impacting, at other people's lives. So thanks to Mr. Kevin. I'm not seeing him. Maybe he left. I don't know. But otherwise, thank you so much, everyone who has participated. And I give back to Mr. Kalemba.
Thank you.
Or if Mr. Kevin is there, can also say a word. Thank you so much for. I was impressed from your presentation about the historical perspective of surgery and the impact on the future surgery. So maybe quickly I can ask you as an elder, what do you think there is a fear, especially in the mind of many people, when they think about AI? They think AI will come and take up our jobs, and maybe tomorrow we shall wake up the robot can do everything. Maybe AI can operate. So what's your take?
Uh, I think Dr. Mumber is off, but I think from what he said, I think he wanted to get Mr. Kevin's perspective on the impact of AI on the future of health and because there are fears that these rapid advancements in AI, especially in the health field, are going to eliminate or cut off a number of jobs. So, looking at the trend about the historical perspective of health and surgery, what's your take on this different stride that's currently ongoing?
Well, throughout history, there have been a lot of new challenges, and people, when they're faced with the new and unknown, myself included, are a bit scared of some of the implications. But I think the lesson is that things do change, but they do also, we need to change with them. So I'm sure with AI, surgeons will find a way of using it to further their own work, just as they found antibiotics were able to take them further in what they did. So hopefully AI will give lots of new opportunities. But the thing is, things change all the time, and things will be different. So exciting opportunities for the future.
Okay, thanks.
Thank you, Mr. Kevin, for that submission. I think let's get the final remarks from each of our speakers and we call it a day. I'll start with Mr. Kevin and Dr. Jagpreet will go last. Mr. Kevin, you haven't unmuted.
I'd just like to say that there are lots of challenges facing you for the future, lots of challenges that are going to be specific to Uganda, but also ones that will be worldwide. And I'm sure that just as surgeons in the past have embraced those challenges and made the best of them, the future is with you to do just that. So good luck with your future careers.
I wish to thank for this wonderful opportunity. For me, it's a big event. First of all, because I have been traveling internationally and doing my own presentations, but having being invited to international level like this has not been very often. As I told, I traveled earlier in 2000 to Gulu Independent Hospital for conducting a training workshop. Uh, Following that, nothing much in Africa. We do have many doctors here from Africa whom I interact regularly. So for me, this one, first of all, it's a big event. It was not really into my what I do every day. What I do, I'm a surgical specialist. I do surgeries. I do a lot of laparoscopic work, and I do a lot of training for hernia. There's a there's a course for the university and Sharjah University and the budding doctors for hernia, pulmonary sinus, proctology within this year, in the coming few months. Well, one of them is dated right next month, starting in a week's time, 2nd and 3rd October. And so that's my main course, okay? So to get invited like this, it was great. Interacting with such an enthusiastic audience was also very good because they were ready with they joined and they yeah, I'm sorry because when the call will come, it will disconnect. As I told, I'm on the working right now. So just I want to quickly thank you all for being a wonderful audience. I want to thank Kalimba for choosing me to interact with you. I'm very happy to interact with you. If my advice can be of help, I am very happy to advise you. As we talk about mentorship, sure, we can work towards mentorship. It would be a great opportunity for me again. Right now, there is so much opportunities online. You can mentor online. And then there is a wonderful thing coming now, AI, which has already arrived. So it's a beautiful thing which is going to change our lives about learning, about how we do our own day to day work. So let's continue to evolve and be curious about all these things. My best wishes to everyone. Thank you very much. Bye bye.
Thank you, Dr. Jagpreet. Last, I would like to get a last comment from you. By drawing, I would like you to help us draw a brief contrast between laparoscopic surgery and then the conventional general surgery.
I'm sorry. What is the question, please? Sorry. Laparoscopic and general surgery. I'm
Uh,
sorry.
um, I understand that you're a senior laparoscopic surgeon, and would like for the sake of record, I would like you to briefly give us a contrast between minimally invasive surgery and the general surgery, the conventional general surgery.
Yeah. See, I mean, a general surgery is, see, for a resident to be trained, it will be great if he can be trained in traditional, conventional open surgery and then graduate to laparoscopy. What we are finding now, the candidates who come to us, the number of laparoscopic surgeries are so frequent, and uh, I also will count the number of times in my last 25 years how many I did open, so I can count them. They're so infrequent, and that's how the trend is all over the world. So the residents, they get exposed to mainly laparoscopic surgeries. They're hardly exposure to open. So I'll say all those who are getting exposure to open, it's a great thing because they can actually touch and have a feel of the organs, have a feel of the things, and before they start doing laparoscopy. Laparoscopy right now is the way how it should be, except cesarean, everything can be done laparoscopy. All general surgeries, laparoscopy has entered, and it's doing wonderful job. It obviously has the advantage of minimal invasion, quick return to work, less pain, quick return to job, and less scars, which is also perceived in a beneficial way by the patient. And then further ahead, there is robotic surgery, and uh, many new exciting things are coming up. I believe as a surgeon, it's imperative on any surgeon to learn laparoscopy. For example, if you do a licensing exam where I work in the UAE, you are expected to be proficient with laparoscopy before you're expected to pass the exam. So that's a basic requirement, not even an advanced thing. So I believe laparoscopy is right now there. I mean, we ought to learn, embrace it, and yeah, get going with it. It's got a lot of advantages. A beautiful thing. As far as from the hospital side investment goes, it's a capital investment. It's not a recurring investment. It's a capital investment one time, and overall, there is a lot of benefit from the advantages that the patients get: reduced stays, or reduced burden on the hospital, quick turnover, more chance to treat more patients. From the patient side, less sick leave absenteeism, so they can join their work. Number of uh, um, days for which they are away from work. So overall, it's a benefit for the nation to get into laparoscopic surgery.
Thank you, Dr. Jagpreet, for that wonderful insight. Apparently, uh, Uganda is a middle income country. We haven't made much strides into venturing into laparoscopic surgery, though it's in existence. Currently, we have around 102 laparoscopic surgeons, and this is mainly due to maybe the higher costs that are attributed to training them and name it. But I understand that the different stakeholders are forging different or strategic partnerships with different organizations to try to see that that the cost goes down and we have more of such a wonderful field or site to venture in. I'd like to thank all our speakers and the audience for sparing their precious time to be present with us. For our speakers, we truly appreciate. We understand you're very busy, but you spared a few minutes to talk to this wonderful audience. Apparently, a number of individuals have uh, have not been able to attend, but then they are going to follow up the event because it's going to be uploaded onto YouTube and onto the other streaming platforms. So thank you everybody for who has endeavored to attend this meeting to completion. And for our speakers, we assure you that your submission and um, analysis won't go into vain. Thank you, everybody. Um, I wish you